Welcome, everyone. This is Mary Marinowski. I'm a medical affairs manager at Nestle Health Science, and I'm moderating today's presentation, Immunonutrition and Wounds. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only. It is not intended as a substitute for medical advice. And so with that, I am very, very pleased to present the beautiful lady you see on the other screen there, Dr. Carolyn Fife, today's speaker. And Dr. Fife completed her family medicine residency at the University of Texas Southwestern and a fellowship at Duke University. And then up until 2013, she was a professor of medicine at the University of Texas Science Center, where she initiated the Memorial Hermann Center for Wound Healing. Dr. Fife is currently professor of geriatrics at the Baylor College of Medicine in Houston, and she's the medical director of the CHI St. Luke's Wound Clinic. She is also the chief medical officer of IntelliCure, a health information technology company, and the executive director of the U.S. Wound Registry. Past and present board activities include the Alliance of Wound Care Stakeholders, the American Academy of Wound Management, and the Association for the Advancement of Wound Care. Dr. Fife has authored more than 100 peer-reviewed articles and book chapters, and her research contributions include most recently real-world data for comparative effectiveness studies to really understand what works best for patients with chronic wounds. So we're in for a treat, and I want to welcome Dr. Fife.
Thank you so much, Mary. I have one disclosure, and that is this work with Nestle Health Science. And I so appreciate the chance to be here today and to talk about some things that I am excited about. Today we're going to talk about wound prevalence, at least among Medicare beneficiaries, and the cost of chronic wounds among Medicare beneficiaries. I'll review the specialized nutritional recommendations from the International Pressure Injury Guidelines. We'll talk some about the data on immunonutrition and wounds. And then I'll show you how I applied an immunonutrition protocol to 2 case studies that were fairly dramatic. And I'm so excited to be here, but you know, a cardinal rule of public speaking is never apologize. But when I found out most of the attendees were dietitians and experts at nutrition, I got nervous because I'm a newcomer to the world of nutrition. You're the experts. And I'm also a little ashamed that in the 35 plus years I've been practicing wound management, I've only had a protocolized approach to nutrition for about 3 years, but it's revolutionized my practice. And you know, there's a saying that what you learn when you think you know it all is what counts. That's the way I feel about nutrition. And this is a paper that I did with colleagues. It was published in 2018. It actually used 2014 Medicare claims data. And it stunned everyone except the authors. And that is, we looked at the total cost of care of all the different types of chronic wounds to Medicare beneficiaries. And while that $32 billion up there says that's what the Medicare spending was, the majority of it, or the lion's share, turned out to be on the outpatient side, not the inpatient side. But the reality is it's not really 32 billion, it's more like 94 billion if you include all of the ancillary downstream costs of wound care. And the reason it's mostly on the outpatient side is that chronic wounds are a chronic illness. They're often present for a year or more. So we're not talking about something a patient has for a brief period of time. And they affect 14.5% of Medicare beneficiaries, at least they did in 2014. As you know, that means the numbers are always going to keep climbing. So even years ago, we were talking about 8 million Medicare patients alone. And so I am going to talk later about the distribution of the different wound types, because it would be easy to look at that previous slide and think they're somehow evenly distributed with pressure ulcers or surgical wounds or diabetic foot ulcers, and that's not the case. I bet the most common chronic wound among Medicare beneficiaries, the most common wound type will surprise you. But the best guidelines that we have in nutrition in relation to wounds are those associated with pressure injuries. And while there are lots of risk factors that have been identified for pressure injuries that you all are familiar with, such as lack of mobility, reduced mobility, or circulatory problems, malnutrition is a ubiquitous one. And malnutrition is important because it is a common theme in every type of wound, even if most of the information we have in terms of good studies are around pressure injuries. And the reality is that wounds aren't a disease. This is how I teach residents. Wounds are a symptom. I'm a symptomatologist, and my job is to figure out what is the wound a symptom of. And part of the epiphany that I had that I needed to step it up about nutrition was this lovely lady who is younger than I am. That's the other thing that gets your attention. And her BMI is less than 14. But in the records I received from her other physicians, no one had mentioned this. I was afraid to let go of her hand when she stood up. That's how frail she looked. And she had bilateral knee wounds that hadn't healed that were thought to be due to vasculitis, but her underlying disease seemed to be pretty well controlled. And really, the only thing that I did for this sweet lady is fix her nutrition a little bit. I gave her some nutritional supplementation, and that was the missing ingredient. We had subsequently went on to develop mathematical models that predict the likelihood of a wound of a given type is going to heal. We can talk about that towards the end. But what's fascinating is that when you look at real world data on the factors that predict healing, malnutrition is a universal risk factor for poor healing in every type of wound you could look at. And so that raises the issue, why don't physicians address these nutritional issues, especially wound docs? And I cannot defend my own actions in the past. I think I could give an excuse, which is not a reason, and that is that we don't screen patients because we sort of feel like it's going to take too long and it's an overwhelming task, but also because if we screen patients and find something, we're not really sure what we're supposed to do about it. We don't know what to recommend. So I had to tackle this in my own practice by first identifying a screening that I thought I could really do. I won't attempt to keep making excuses for my colleagues. I can only report on my own behavior. But I picked the mini nutritional assessment because I had been validated for older patients. The average age of my patients in my practice is 62 years old. And it's simple for me to implement, and I'm big on simple to implement. And the thing that impressed me the most really is that it only takes me a few seconds to do this. The fact is the nurses will have already calculated the BMI. It's an automated feature in the EHR. And so that little bit of time is already abstracted away. And I'm in the room with the patient looking at them, so I know what their disease history is and how mobile they are or aren't. And I know whether they have acute disease history and neuropsychological issues. So really, these things are already visible to me just on the casual overview of why the patient is at the wound center. That means I really only have to ask two targeted questions, one about whether their food intake has declined and the other is whether they've lost weight. And so I can do this in a few seconds. That is a big deal for me. And then I should point out that I can understand what the results mean. And that is, if they have a score of 7 or less, then I know that they're nutritionally at risk. And so the beauty of the MNA is that it has been studied prospectively, and an MNA score less than 8 was more sensitive than the Braden score at predicting future pressure ulcers. Now, of course, remember, when I'm seeing patients, they've already got a problem. They've already got a pressure injury. They've already got a non-healing surgical wound. So I don't really need to predict what's going to happen. But here's the sad reality for patients with chronic wounds. 30% of them will get a new one while we're taking care of them for the one they came to us for. Isn't that a sad statistic? that the interventions we're doing, for one thing, are not fixing the problems that make them at risk, and nutrition is the theme that tends to be the ongoing problem that we're not very good at fixing. I'd also like to add that in this same study, there were significantly lower plasma arginine concentrations on admission in individuals who developed pressure injuries. And I'm going to get back to that in just a second. So I finally decide I'm going to get methodical in my approach to nutrition. And the first 40 patients that I screened, 37.5% were normal, 25% were at risk, and 37.5% would be considered malnourished according to the MNA. Now, even a doctor can figure out this patient is malnourished. Even I can do that. But I probably would have missed it on this lady. And this is a woman who has vasculitis. She has got a lot of serious health problems that I wouldn't just take a glance at her and assume that she needs nutritional supplementation. So my reality check very quickly was that 62% of my patients needed some sort of supplementation based on the MNA, even if they didn't already have a wound, and the vast majority of them have a wound. So now what am I going to do? Because I guess I would call this the simple girl approach to nutrition in patients with wounds, because as a doctor, I can tell you I need it simple. And that's the reason that I highlighted this particular section of the nutrition guidelines for pressure prevention and treatment of pressure ulcers injuries. And that is, remember, my patients already have wounds, stage 2 or greater. They've got full thickness wounds. And you may also be interested to know that for 10 years, we've been looking at this with the US Wound Registry, and across the board in millions of patients, the average patient has 2.2 wounds per patient. They don't just have one, and depending on the subcategory you're looking at, they often have many. So these are patients who need high calorie, high protein supplementation. They need L-arginine, they need zinc, and they need antioxidants according to these guidelines for pressure injuries. So I told you that I need it simple as I'm thinking about protein, and at least I do understand the purpose of protein. I think most physicians can get that far, that we're not going to get angiogenesis without protein. We're not going to make collagen without protein. I think I will confess that the immune importance of nutrition is not something that I really feel I got in my training. But as you know, protein has an impact on leukocyte formation as well as platelet function and fibroblast proliferation. And I need it simple, so I can remember about 2 grams per kilo per day for my patients, because remember, they've got at least 2 full thickness wounds. So I can remember about 2 grams. And in terms of calories, I can remember about 40 kilocalories per kilogram. I realize you do very elegant calculations, but I need something that I can move forward with in a logical way. And of course, we understand the issues of hydration. I've already shown you pictures of patients who not only were malnourished, but you can tell that they are not well hydrated. So I think that the next reality check that I had to do with L-arginine. And I probably understood the fact that L-arginine as a precursor of nitric oxide has an impact on tissue oxygenation. And I already knew that diabetics tend to be low in L-arginine. And I think I probably knew that L-arginine is important for collagen production. But I will tell you the part that I absolutely did not understand was the role of L-arginine in T-cell proliferation and immune function, and the fact that it could decrease the risk of infections. That is not something that I would say that I appreciated as I began my journey of trying to do a better job. And there were several cases that brought this home to me. And so I'm sharing them with you because this is a part of my journey to understand what I needed to do better. This woman is young. She's only 33 years old. She's a diabetic who failed a transplant. She's been on peritoneal dialysis at home. She's had a non-healing surgical wound for the removal of one of her transplants for 9 months. She's been seen by 3 different teams, including our transplant team, which is a spectacularly good medical team. And no one thought to talk to her about nutrition. And I did something I didn't think I'd ever do. I took a food history, and it turns out she's very picky about texture, and she had a weirdly limited diet. And the only change that I really made for her is that I started her on L-arginine supplementation, and over a period of a few weeks, this wound that had been making no progress for 9 months completely healed. And this message about L-arginine has been brought home in some slightly embarrassing ways. This gentleman has an above-the-knee amputation, and when I first saw him, bone was clearly exposed, although you can't see it very well in this picture. I made an appointment for him to go back to see the orthopedic physician. If you are familiar with how wounds look when they're getting negative pressure, you can see the indentation of the foam, which is very characteristic. But he'd been started on negative pressure without anyone paying attention to the fact that he had muscle wasting, that he was depressed and wasn't eating. I got him started on L-arginine, and in a week, by the time he went to the orthopedic surgeon, the bone wasn't exposed, and the orthopedic physician very condescendingly explained to him that I just didn't know what bone looked like, and he went on to heal very quickly after that. Remember, he'd had an amputation that had had a primary closure and then dehisced, and we were working on this almost surely because he was malnourished to begin with. And this gentleman has a very low BMI. It's very obvious that he's starving. His case is very sad because he has a 100% fatal genetic neurologic degenerative disease. And the family made the very brave decision not to put in a feeding tube. And the saddest part is that he's alert mentally but can't speak. And he used to be a very stout, muscled man. And he had a very large sacral pressure ulcer that undermined extensively, and I could see sacrum when I looked up in this hole. So I decided to start him on L-arginine, which the wife thought she could manage, in addition to a little bit of calorie supplement from a drink. And I had no expectation that he was going to heal. I was just trying to make him comfortable. And within 5 months, the undermining was almost completely gone. And I will tell you, I've been at this 30 years. I didn't think we could fix undermining anyway except surgically. And within 6 months, he was completely healed. So I don't know that I've ever seen a better example of the difference that L-arginine supplementation alone can make in somebody who's still not getting enough calories. Although that's not that we would recommend that. It was a unique situation, but a profound example for me and for my nurses. So after this poor gentleman who we'd had in palliative care completely healed, really with only L-arginine as a change in his plan, my nurses got as excited about this as I am. And I'll hear them in there talking to wound patients about L-arginine. Why? Well, there's data to support the fact that L-arginine is useful even if patients have a normal nutritional status. This was a study of 18 spinal cord injury patients, really all but one was considered to be well nourished. They were supplemented with L-arginine, vitamin C, and vitamin E, and then their healing rate was compared to historical controls. And the group receiving the supplementation healed at least twice as fast as their historical control counterparts, sort of regardless of how severe the wound was. Those are the orange bars, and a shorter bar is what we're looking for because that means fewer weeks to healing. So that made it easy for me. I could say, okay, I need a simple girl approach. I can give L-arginine. I have reasons to give L-arginine to every single patient with a wound that I see, regardless of how they roll out on a nutritional assessment. But as you well know, the things that patients need are not just limited to calories, protein, and L-arginine. They need zinc because it's an important cofactor in lots of enzymatic reactions, as well as fibroblast proliferation. They need vitamin C for antioxidant purposes, for their immune function, and for fibroblast proliferation. Can't make those blood vessels without it. They need vitamin E, they need selenium, they need copper, they need manganese. So I often will tell patients, hey, most of the multivitamins are going to have the amount of zinc and antioxidants that you need, but in some cases, they're going to need more. And so that takes me to the thought process of what kind of evidence is there for disease-specific nutritional support for pressure injury healing. And this is a systematic review that was written into guidelines that have 273 total patients in all of the 3 RCTs with stage 2, 3, and 4 pressure injuries. And they compared a formula that had L-arginine, zinc, and antioxidants to standard protein calorie supplementation. And the specialized formula significantly reduced the surface area of wounds, and a higher proportion of subjects had more than a 40% reduction at 8 weeks. So what we can conclude from that is that high calorie, high protein formulas that also have L-arginine, zinc, and antioxidants are preferable to those who don't. So now here I am back with a typical day. This is not an unusual day for me. A patient who has profound edema on her lower extremities, but she's got muscle wasting. Patients who have tremendously low BMIs. I'm shocked at the, it's a dichotomy. There are many obese patients, but there are almost as many patients that are clearly malnourished. And this gentleman who had a dramatic weight loss after a motor vehicle accident, what you can't see in this picture is that underneath that sagging skin on his flank, there's a non-healing wound. So now it's easy enough for me to say if you have a wound, you need L-arginine, but I clearly have patients that have an MNA of 7 or less, and they obviously are in trouble, but I don't have a registered dietitian to help me. I have to think of something that is implementable for me without the special expertise that you have. And so once I know I have a malnourished patient, which I would almost go so far as to say if you're in my waiting room with a chronic non-healing wound, you probably are malnourished, but you certainly are at risk. So once I have a patient with a full thickness chronic wound, I know they need calories and protein, and I know they need specialized nutrients. And as it happens, oral immunonutrition has been studied for 30 years in surgical patients. So I felt that I could extrapolate from that surgical data, take the contents of those recommendations in surgical wounds, and apply them in some organized way to my patient population. That seemed to be a fair thing to do. So this is what I call my simple girl approach to nutrition in patients with chronic wounds. And I don't even bother to talk about partial thickness wounds because partial thickness is a blister that has popped. If that is what your problem is, you are not in my waiting room in the wound center. All of my patients have fairly horrific wounds. I'm going to be looking at muscle, bone, tendon on a regular basis with these poor patients. And they tend to sort of fall into 2 categories for me. The ones that are relatively well nourished and their MNA score is often 8 or better, and the ones that are in trouble. They're obviously malnourished or at risk of malnutrition with an MNA of 8 to 11 with weight loss or 0 to 7. So I think of them as 2 groups, even though that may be an oversimplification. I'm going to give L-arginine to everybody who's got an open wound because the data support that. It's a little trickier with my malnourished patients because I know they need more. How am I going to handle that? Well, if they don't have renal disease, then I can give them a very high protein immunonutrition oral supplement that has L-arginine and calories and is carbohydrate controlled if they need it. And then if they are not on dialysis, but they have significant renal disease, I'm going to call the nephrologist. About 8% of my patients are on dialysis, and about 8% of them are close to being on dialysis. But for the ones that are on dialysis, I'm going to give them a calorie-dense oral nutritional supplementation with protein and electrolyte control. And if I'm worried about something, I'll call the nephrologist anyway, because I often have questions about their vitamin D, and that's something that I don't feel I can supplement myself if they have a renal problem. Everybody gets protein source counseling. And these are the handouts that I use. And what I love about my nurses is that they've seen such a revolution in the time it takes to heal and the general appearance of our patients that I'll hear them in there beginning the conversation about making protein a priority even before I can get in the room. They're talking about protein while they're taking off the dressings and measuring the wound. It just becomes so much a part of the overall experience of coming to the wound center. And I actually asked people what they had for breakfast. And a typical scenario for some of my tiny little ladies who have a 2-carat diamond ring about to fall off their finger because they've lost so much weight, they have a Danish for breakfast, a sandwich for lunch, and cookies for a snack, and then they're not hungry for dinner. Their diet is almost devoid of protein. So I talk a lot about nuts and peanut butter and ways in which they can get extra supplementation, and ask the family, can't you make these available? Just put them by the bed and let the patient just snack on them when they think of it. And so I think these two cases are really representative of the way that this little kind of simplistic algorithm can be used for patients with limb-threatening ulcers. They're quite different cases, but both of them had limb-threatening lower leg wounds. They were both malnourished according to the M&A, and we knew that they were going to need limb salvage surgery. So at their initial visit, we stressed the importance of high protein foods and protein immunonutrition. And when I say we, I'm talking about our team, it's not just me. And we asked them to commit to consuming 2 to 6 cartons a day of immunonutrition, at least an additional 400 calories a day, with 36 grams of protein and 8.4 grams of L-arginine, and did a taste test in the clinic because we were going to give them a month's supply of their immunonutrition. And I wanted to make sure they were really going to drink it. And if they passed the taste test and said, yes, I'll do this, we gave them a diary that they could bring back to us to confirm that they had done what we asked. And that's how we began this particular case, which is a gentleman I still see occasionally. You can see the muscle wasting of his thenar eminence in this picture where his thumbs are. Profound muscle wasting. He's only 57. He'd lost 15% of his body weight in the past month. His MNA was 7, and he had an exposed tendon due to pyoderma gangrenosum, which is a very rapidly spreading autoimmune type of problem that's supposed to be rare, but I have a whole clinic full of these patients. The problem had been worsening for 4 months before I saw him. I had to start him on 60 milligrams of prednisone a day, which is a whopping dose. And he agreed to do a month of immunonutrition, high protein supplementation. And this is how he looked when I first saw him. The wound is getting bigger because pyoderma is a nasty, rapidly spreading problem, but he's actually got a little granulation tissue, even while he's got a progression of the wound. That's a fascinating thing to see. And then we knew always that he was going to have to go to surgery for this exposed tendon. So after about a month, almost 2 months, after he finished his immunonutrition for a month, I just gave him samples of L-arginine and helped support him getting a protein calorie drink. And then he was taken to surgery. The tendon was excised and a skin graft was placed over it. While he's on very high dose prednisone, and he healed completely, he's still healed 8 months later. So I find this to be a dramatic case. And to me, one of the things that I find so interesting is that we didn't really have a choice but to do surgery on him, but many times the donor site develops pyoderma, and you start this process all over again somewhere else. And it seems to me that there's been an advantage to his body inflammatory process with immunonutrition. This other woman was also very young, 34 years old. She'd been in the hospital 21 days with sepsis in the ICU. She had disseminated intravascular coagulation that caused her to develop foot ischemia. She came to see me 3 months after she was discharged. She had lost 15 pounds during that time. Her MNA was 7. She had 2 very large ischemic ulcers on the left lateral plantar foot and the lateral side of her foot and the plantar foot. And when I checked her skin perfusion pressure on the lateral side of her foot, she didn't really have adequate flow in the vessels. That's because she had lost some of her vessels to clotting during her DIC. And so we did the same thing. We did a taste test. We got her to agree to a month of immunonutrition. Initially, this is what her wound looked like. There's really no evidence of healing. But within 2 weeks, she's starting to develop granulation tissue, even in an area that my screening suggests she doesn't have enough flow to heal. And then she went on to surgery and was able to primarily heal an excision of these necrotic areas. This is this young woman. She has to walk with a brace, but nevertheless, she's ambulatory. So the takeaway here for nutrition in patients with chronic wounds is to consider giving L-arginine to everyone, no matter what their nutritional status might be. If they have a wound, to me, they warrant L-arginine. And then use a standardized tool to identify malnutrition or patients at risk of malnutrition. And then reinforce what the family can do because they want to help. The focus then becomes whether, in addition to L-arginine, they need more calories and protein, not to mention the fact that they also need zinc and other antioxidants. And I check everyone's vitamin D level. We could perhaps talk about that in the question and answer time. But the reality is that immunonutrition has a role in chronic surgical wounds. And in case you were not aware of it, I'm the executive director of the U.S. Wound Registry, and we are able to design quality measures for physicians and registered dietitians to report to CMS under the MIPS program, the Quality Payment Program. And CMS approved our screening for a nutritional status in patients with wounds and ulcers as a quality measure about 2 years ago, and it continues to be a measure that can be reported for satisfying MIPS. But as I wind down, I wanted to point something out about that study that I discussed at the very beginning of the 2014 Medicare data. And that is, we have so much information about nutrition and pressure ulcers, but I want you to see where pressure ulcers injuries are in the frequency distribution of all the wound and ulcer problems that we take care of. They're really a small problem compared to the big problem of surgical dehiscences. And what I call the wounds with no name. That is the traumatic wounds and the chronic ulcers people have, and they don't even know why. They hit their leg on the dishwasher door, they hit their leg on the coffee table, it never got better, or this wound just came up, I don't know why. When you combine the wounds with no name, those traumatic ulcers that never got better, the chronic ulcers, no one knows why they have them, with the surgical dehiscences, the lion's share of those are actually evidence of malnutrition. That's really their problem, and we're missing it. And I think, as I mentioned, the thing that really proves the point is that when we look at the risk factors that predict whether a wound is going to heal, in every wound type we look at, a statistically significant variable is malnutrition. And that's diagnosed malnutrition, which, as you know, is poorly diagnosed. So thank you for letting me tell you about my journey in trying to learn something more or do a better job with nutrition. And I think Mary's going to help me field some questions.
Thank you so much, Dr. Fife, for an excellent and a timely presentation. I'm looking at the questions coming in through the questions pane, and I'm also looking at all the questions we received when people registered for the webinar, Dr. Fife. And
Okay.
I've been able to group some of these questions into some categories. One of the first questions we had both from attendees when they registered and from the audience today was, how much L-arginine supplementation is needed and for how long?
So that's a great question. And I can only tell you what's in the literature, which is I think I mentioned the Serrata study that supported 6 to 8.5 grams per day of L-arginine for 8 weeks. And Brewer, which had 9 grams a day until the wound was healed, which is about 10 weeks on average. Our average healing rate is more like 12 weeks. And I personally keep patients on L-arginine until they heal, even if it's months, which sometimes it is. I can't give you any independent thoughts on what the right dose is, only that that's what's been used, and that's what I recommend.
Okay, thank you so much for that. In terms of your algorithm, what would your rationale be for applying the pressure injury guidelines to other types of wounds that malnourished patients have?
So remember, this is just me talking, but I don't believe that metabolically, any wound is different from any other wound. And I might add that 50% of our patients with venous ulcers have diabetes. And we don't call those diabetic ulcers. They're still venous ulcers in people with diabetes. So, but if you ask me, what do we do that's wildly different, even in terms of debridement or getting rid of bioburden or our dressings that we put on the wounds, like we treat all wounds the same with a few little things like diabetic foot ulcers due to neuropathy get offloaded in venous patients with edema or putting compression, but and patients who have pressure injuries, we want to make sure they're on the right support surface. So we do that, but otherwise a wound is a wound, and they all have to heal by making fibroblasts and angiogenesis and collagen formation. They're not different just because we give them fancy names. So it's very difficult for me to believe that what works in one wound model doesn't work for the others. If we get more data, we may be able to make subtle changes in those recommendations, but I think we can extrapolate. And particularly, I think we can extrapolate from the surgical literature, which is also very good.
Okay, thank you so much for that. In regards to the case study results, in this case, are really building upon what you just said. In regards to the case studies, would you expect similar outcomes with chronic wounds in your patients that have diabetes?
So first of all, I would say, both of those cases were chronic wounds. And I do see the same outcome in diabetic patients. The challenge always is with diabetic patients who have neuropathy, the thing that will slow them down is failure to offload. And sometimes that is almost impossible if they're in any way ambulatory. But that's not because they're unable to heal. It's because they continue to re-damage the area. So other than being careful about glucose content, and in people who have renal insufficiency, being careful about some of those other electrolytes that they have to be monitored, there's nothing unique about diabetes that makes their healing unresponsive to good nutritional supplementation. I'm not enough of an expert to give you any more specific insight into diabetes metabolism, except that from a broad perspective on wounds, I think we can confidently extrapolate data as long as we don't give them too much sugar.
Okay, thank you. Thank you. And we just had a question come in about vitamin D status and, wanting to understand more about how that impacts wound healing.
Yeah, so again, this is just me. I always feel a little awkward since there are people who probably know vastly more about this than I do. But here's my story about vitamin D. I'm the editor, the clinical editor for Today's Wound Clinic. And a few years ago, we got a beautiful article about the role of vitamin D in healing. And because I'm the editor, I was standing in the hallway on my iPhone editing this, or at least reviewing the galley proofs to make sure there wasn't anything that was going to be a problem if we published it. And so I had just skimmed through this fabulously written article about all of the reason why vitamin D is so vital to angiogenesis and collagen formation. And then the patient's ready, and I walk in the room, and it's a relatively young woman. She's an adult. She'd had juvenile diabetes all of her life, and she had had knee replacement that had dehisced. They had to go and put a new knee in. So this is her second knee replacement. She dehisced again. She has negative pressure in place, and the negative pressure sponge just fell out. She had no angiogenesis at all. Her tissue was pale. And I was looking at her thinking, there's something big that's obvious that I'm missing. And I stood there for a moment and said, I'm very fair-skinned, but you are the queen of the undead. If you don't mind my saying so, when was the last time you went outside? And she said, outside? Other than to walk to the car, I haven't been outside for 2 years. Her vitamin D level, because I just read this article, her vitamin D level was 8. And all we really did for her was normalize her vitamin D. And she started to make granulation tissue in response to negative pressure, and she closed the wound. And the horrible reality of that is she'd had 2 knee replacements without her vitamin D level being checked and had failed almost surely for that reason alone. So I began to check vitamin D level on everybody with an open wound, and 85% of those patients have a level less than 30, many of them in the teens and single digits. It's a cheap supplement to give. And when we fix vitamin D, not only do they start to make blood vessels, many of them become less depressed. And we have had kind of miraculous changes in personality where, you know, those patients you draw straws on who's going to see them today because they're so despondent and unhappy, and they come in smiling and joking, and you're wondering if maybe somehow they got replaced with a different person who looked just like them. So vitamin D is absolute for me, that I check it every time. And then
Okay,
I
thank you.
either take 8 to 10,000 units a day, or I do the 50,000 unit once a week. But I really think it gets up a little higher if they're willing to take a daily dose of D3.
Great. Thank you so much, Dr. Fife. There are quite a few questions about supplementation of vitamin C and or zinc, separate from amounts that would occur in a nutritional supplement or formula that's providing calories and protein. And so two things. One is, do the NP or the International Pressure Guidelines, do they address supplementation of vitamin C and zinc? And whether they do or not, what do you do in your practice?
So the NPIAP guidelines do not address vitamin C and zinc. And I hope that someone who's watching is going to tell me what I ought to do. I'll tell you what I do. And that is, I tell them to get the zinc preparations, the zinc and vitamin C preparations, people that are marketed for people with a cold, and to take those. And what's interesting is that lots of patients come to me on vitamin C already. And the beauty of vitamin C, of course, is that about the worst thing that can happen is that the patients will make expensive urine if I give them too much. Vitamin D, I do have to monitor that, and I do check it about every 3 months. But I don't feel they can hurt themselves with vitamin C and zinc, but I insist that they take their L-arginine and that we check their vitamin D as well. So I use the I'm getting a cold preparations because the patients will like the fact that it's already sort of figured out for them. I hope somebody who's watching will give me better advice than that.
Well, there was one question, just asking too, if you check serum levels of anything besides the vitamin D.
No, I don't. I do check in certain cases because I'm getting a CBC. I'll check B12. I do have lots of patients who've had gastric bypass surgery and aren't taking supplements, and they're anemic and with big cells, which implies that they really need B12. If I should, I hope you'll help me figure out what I should check. I am aware that it can be difficult to get some of those reimbursed. And one patient came in with a letter from Medicare saying that their doctor should have known not to order a vitamin D level. It's a very awkward problem when we're struggling with the payers for some of these. I think I've gotten a little more savvy about the coding, but part of my angst is the challenge of making sure that I've attached the right codes so that the patients don't get hate mail from the payer that they are going to have to pay for lab tests their dumb doctor should not have gotten. The payers are not helpful to my goals.
Well, it sounds like you do a lot of work helping the patients or trying to navigate that. So that's awesome. There are a lot of questions coming in about renal disease. Patients that have kidney disease, of course, are often limited in the amount of protein they can consume if they're not on dialysis yet.
I'm so aware of the protein issue, but I'm having such fabulous experience with L-arginine that I push the L-arginine when people have protein limitations. I don't worry about their protein. I just get them to take L-arginine. And I also keep sample packets of things on hand in the clinic so that I can say, take this to your nephrologist and let them read the back. And if that way they can give you some comfort that this product is okay for you. And so far, I've never had a nephrologist say, no, they can't take that. So I focus on L-arginine when I can't do protein. And
Yeah.
that's fascinating message is that poor man who was starving, um, and yet he healed a horrible pressure ulcer with L-arginine. I'm not saying that I recommend that, only that it's possible.
Okay, thank you. Thank you so much. I know that's an extremely challenging population to work with, and it's wonderful that you have that rapport established with the nephrologists, because it really, in my experience, as I'm a former renal dietitian, each of those patients, whether they're on dialysis or not, are very individual in what they can tolerate and not tolerate, depending on a whole bunch of different factors. And so having someone like the nephrologists or the renal dietitians that are very, acutely aware of that patient's history, pulling them in so that you have that, expertise to bring to your wound patients, I think is so important.
Yes,
Uh,
because I'm very quick to admit that my simple girl approach is not good enough for renal patients, and I well know that. But Mary, I gave a talk similar to this to a group of physicians, and I got a question that really scared me, which is a doc who said, "What if I do the wrong thing?" And and I said, "So you're doing nothing now about nutrition, and the thing you're most worried about is that you'll do the wrong thing, not that you're doing nothing." It's sad to think that we're in that place where the enemy of good is perfect. We don't want to hurt anybody, but we have a long way to go just to hit the bottom threshold of doing the job. So I just think it's sad and interesting that physicians are more afraid they'll do the wrong thing than the fact that they're currently doing nothing. Maybe that's first do no harm, but I would say that our sins of omission are far worse than our sins of commission, at least where we are now.
Thank you. Thank you for that. The next question is in regards to, if you're working with a patient that would have a full thickness pressure injury or other type of chronic wound, and they happen to be obese. I remember the one picture you had in your slide deck where you said you might have missed their malnutrition if you hadn't have done the screen. Do you approach, you know, encouraging or establishing some protein and calorie goals for them in different ways because of them being obese?
So, yes and no. I try to get a food history from them, which is trickier than it might be in people who know they don't eat very much and think it's enough. But when you do talk to people about their diet, as you know better than I do, it tends to be very high carb and low protein. And so, in point of fact, while we don't want them to gain weight, if they could exchange some of their carbs for protein, they would be better off. And we might get their wounds healed regardless of whether they normalize their weight. And with somebody who's got a really bad pressure injury, we're not gonna, we would like for them not to gain weight, but if they would maintain their same weight and optimize their protein and take L-arginine, then they'll heal, and then we can do a little better job at trying to deal with the lifestyle issues that they have. I don't know if that was a good enough answer,
No,
but
it's a great, no, it's a very, I think, practical and realistic answer. And the other thing that it brings to mind is just, it sounds like you see them fairly regularly so that you are
yes,
able to be aware of what's going on with their weight, et cetera.
exactly. That is such a good point, is that I see most people weekly. That some of the people who are paralyzed or bedbound, I see monthly. But that's still often enough to know whether they're taking their supplements. So every time they come in, and of course, the thing no one's mentioned that I think is the elephant in the room is the cost. It's a problem for lots of people. And so I'm also trying to figure out whether that's the barrier if they're not taking it because they don't know how to use a computer, they don't have a computer, or it costs too much to get it on Amazon. And so I have a network of scheming ways to try to help get people things they need. But I get a chance to ask them very frequently, and I can weigh them frequently. And I have a lady that I just saw this Monday, and she knows she's going to get a lecture if she isn't at least 90 pounds. So when I walk in the room, she will say, I'm 91 pounds today. Like, go ahead, and you can't get mad at me. Her intake is so marginal. And it's very interesting. I'm in an affluent area, which I didn't used to be. And I think we have a lot of ladies who are amazingly high functioning anorexics. They've been wearing tiny clothes, fashion clothes, and they're afraid they're going to gain weight even when they're already very thin. And I focus on vitamins and L-arginine on those patients. I try to get them to increase their calorie intake, but if that's going to be a losing battle, then I show them how many calories are in a package of L-arginine and convince them they will not get fat if they take it. At least I can get that going.
Okay, thank you. Thanks very much. I mean, that's the whole spectrum there, from the obese patient to the anorexic one. In terms of supplement compliance and the taste, do you have, this is another question that just came in, do you give them any tips on how to mix it or make it taste better?
I just tell them get it cold. And I will also suggest that they get old-fashioned ice cube trays and pour it into ice cube trays, and then eat the immunonutrition like little popsicles, or freeze little medicine cups. Because if you have a family member who's committed so that they keep working on them throughout the day, then they can put away a bottle if it's semi-frozen with a lot more palatability. I do have the recipes, but often instead what happens is family members are trying to figure out how to make a milkshake that they will drink. And if they don't have diabetes, I give them permission to put their immunonutrition in ice cream if the patient can have ice cream. So, you know, when you've got somebody who weighs 91 pounds and isn't a diabetic, you know, have at it. But you're right, taste is a challenge. And that is true even for L-arginine, because while you know, most people don't mind fruit flavored things, everyone has their little quirks. And so it can be a challenge to tell people, hey, you know, this particular fruit flavor is the most popular, most people like this. And I try to get samples of different flavors and give them different samples and say, here's this flavor and that flavor, why don't you try them and then get the flavor you like best? And I really think that helps, because they are a little bit more willing to purchase something if they've tasted it and say it's not going to be horrible.
Fantastic, fantastic. Well, we're getting to the top of the hour here. I want to thank you again, Dr. Fife, for an extremely informative presentation. On behalf of the Nestle Nutrition Institute, we hope you found this information useful to your practice. Enjoy the rest of the day and please be safe.